So now I'm going to introduce Susan Newcomer. And before I bring her up, I just wanted to say that Chris Gordon sends his apologies. He's not feeling well. He caught a stomach flu, and so he's not going to be with us today. But Chris was our program officer when we originally wrote this R13, and it worked really, really well, and our plan was to renew it when he told us that the leadership at NIMH decided that this thing had gone so well that it was a fully mature network and they had no interest in continuing to support meetings, which came as some surprise. And, you know, I knew Susan because she had worked with John Jamat in capacity building initiative in Botswana for HIV prevention. And I had some roles in there. So, you know, I was chatting with Susan and lamenting, and she said, well, let me see what I can do. And we had a number of conversations, and Susan actually paved the way for us to submit this most recent, the one that's now expiring, version of this R13 to NICHD. Not only did she do that, she paved the way so effectively that we had money from heart, lung, and blood, from aging, and I believe from cancer as well, that helped fund this last iteration of the R13. Well, you know, now at this point, NICHD has also changed its policies some, so we're going to NIAID, where this actually, in my mind, properly belongs. But I just want to say that we're very, very grateful to Susan. She was our champion. She pulled us from the brink of the abyss when we really needed it.
That application got a perfect score. I didn't do that.
Okay, thank you. But anyway, that's why now that Susan has retired, we thought, you know, that she's always spoken her mind in any case, but now she's completely unfettered. So we invited her. We wanted to ask her to reflect on her career and to outline what she sees as some of the challenges moving forward. So I give you,
Thank you,
Susan Newcomer.
Thank you all. I mean, I have enjoyed every single minute of working with this group and with the folks that have been in my portfolio. I've got a really short presentation, and since I retired, I moved to an Apple computer, and I never did figure out about PowerPoint, so I haven't got any slides at all. So you'll just have to put up with the picture of San Francisco. So I came to being a Fed really, really late. After life as a wife of an enlisted man in the Army, wife of a Foreign Service officer, wife of a graduate student, wife of a faculty member in the political science department at Iowa State, a YWCA director, a graduate student, the director of education for Planned Parenthood Federation of America, and then I became a Fed. And all of those wife of, that was the same man. He just moved around a lot. So I have had a lot of experience before I joined the federal government. Well, I started at NICHD in October of 1988 as a special expert, hired temporarily to assist the city of Baltimore in evaluating their teen pregnancy prevention initiatives, which were not exactly initiatives. This was a clever way that my then boss, Wendy Baldwin, decided to get me hired, because I was going berserk as the director of Planned Parenthood at PPFA, because the affiliates, as you may know if you've worked with them, each has their own education department. And so I, as the director, the national director of education, would suggest to the affiliates that they do something. The educators there would say to their boss, and their boss would say to my boss, tell Susan to back off. those educators work for me, not for her. So it was a bureaucracy at that point, and I was looking for something else to do. Wendy hired me. And over time, after she hired me, we weaseled my way into being a real Fed rather than a special expert. My responsibility was informally defined as a sexpert bureaucrat. You notice in the program, it's listed as expert bureaucrat. I think that's because spell check didn't believe that sexpert was a word. I believe it is. And now I got that title, in fact, because I was working on sex, contraception, and then HIV. And then I retired, as Michael said, I retired at the end of May. And Michael and I sort of informally decided that the title of this talk would be Susan Newcomer, Free at Last. Well, I have not, and my job at NICHD, I never, until very recently, like maybe first Tuesday in November of last year, never felt really constrained, that I was pretty much within bounds of civility left to do the kinds of things that I thought were important, that you thought were important. There are constraints, of course, on confidentiality and respect, and once I did ask our then director, Dwayne Alexander, if I could issue a funding opportunity announcement calling for research on abortion. And he said, get real, Susan. So no, I didn't. But family planning, yes. Now, in terms of where I am in the bureaucracy, a little sort of setting, the Department of Health and Human Services has 80,000 employees and 11 divisions, including NIH. NIH is one of the largest divisions. It has about 20,000 employees. The NIH director is appointed by the president, as is the director of the National Cancer Institute. All the other institute directors are appointed by the director of the NIH with some approval, but they don't require congressional approval. So the director, since 2009, has been Francis Collins, who's a geneticist. And NICHD is one of the middle-sized institutes and we had 15 sections with about 1,700 employees. The director since 2016 is Diane Bianchi, a geneticist. Is there a pattern here, maybe? Then the NIH Division of Extramural Research manages 13 sections with about 800 employees. My then branch, the Population Dynamics branch, has 6 employees, 5 professional staff and an administrative assistant. So I am one of 80,000 people in a bureaucracy. So this is a worm's eye view of what I saw then and what I think about. As I said, I started at NICHD in October of 1988, when HIV was still GRID, although it had been recognized as a disease since 1981, and there have been some people, including our awardee later on today, Tom Coates, who's been working in the field of HIV prevention for a long, long time. Well, I had come from PPFA, where I had just organized a 2-day seminar on sexual behavior research, which was not something that the Planned Parenthood really wanted to deal with. Family planning, yes, but family planning was, and sex was exposure to the risk of a fertility event. It wasn't sex. So some things don't change. And before I got my PhD, I worked at the YWCA on the Iowa State campus in Ames, Iowa. And I helped run the sexual attitude reassessments there. Does anybody remember SARS? Well, they were started at the University of Minnesota. And it was a weekend workshop on sexual behavior, sexuality, thinking about reassessing one's own behaviors about sex. And Mary Briggs, who was one of the people at Minnesota, came down to talk to us once. And I remember she said, well, one of the reasons that Americans are so weird about sex is because we get this double message. Sex is fantastic. Sex is wonderful. Don't talk about it. And sex is nasty and dirty and disgusting, and you save it for somebody you love. And she said, no wonder people are crazy. So, that really hasn't changed in many senses. Sex sells, but other than that. So I came to NICHD as a special expert to assist Baltimore in evaluating the effects of their school-based clinics. So they had some of the first school-based clinics. Lori Zabin, who had been at Planned Parenthood there, got money from I'm not quite sure where to start a school-based clinic there, talk explicitly about family planning. So I spent a lot of time in Baltimore, a lot of time with the folks at Hopkins, with no funds except my salary and the mileage to get up to Baltimore. But as HIV got more and more attention, media attention, and more people were found to be infected, NIAID and NCI were funding most of the biomedical research. NICHD was still thinking about family planning and not much about any other kinds of, and again, more focused on exposure to the risk of a fertility event than anything else. But we did have some expertise in issues around sexual behavior, because familiar from the family planning world, the researchers. But then again, at that point, the NICHD was interested, and still is interested, in funding the development of new contraceptives rather than on why people don't use the ones that are available. At that point, my branch, Wendy Baldwin, and some other people from NIMH were holding what was known as sort of the AIDS lunch. Once a week, they would get together and talk about AIDS-related issues. OAR was also funded in 1988, I think, Paul, right? And they got more of the focus on where the money for AIDS-related research was focused and funded, channeled through NICHD. And its total of the NIH budget allocation grew from less than 1% in maybe 1987 till about 10%, and now it's beginning to get smaller. Even as the whole NIH budget doesn't change, the proportion that's going into HIV/AIDS research is changing a little bit. And of that, I'm here to tell you, only about 4 or 5% goes into social and behavioral science research anyway. So you all are doing a good job in being persistent in making sure that attention is paid to HIV. Well, who decides on funding priorities? I'm sure that everybody will have their own tale on this, but in effect, it beats me. Theoretically, each institute has a standing advisory committee that meets 3 times a year, and there are several other high-level advisory committees which also meet on various and sundry ways. And there's the one I will tell you a little bit about, because it's one I was intimately involved with, is one to redesign the contraceptive program at NICHD. It met a lot of times, had a lot of biomedical people and 2 or 3 social scientists on it. They wrote a report that in the end was, we staff people were told that it was too sensitive for us to see it. We were supposed to respond to it, but we couldn't see it, which was very interesting. In effect, I don't know how much attention is paid to the advice that these people give. But again, we think that one was more on should the NIH develop male contraceptives or female contraceptives, not should the NIH look at more about why people don't use the contraceptives that are available. I was struck about ART failure and contraceptive failure. By and large, it's not the ART that fails. It's not the contraception that fails. If you don't put a condom on, it doesn't work. But if you say you're using condoms and you haven't used one and you get a disease or your girlfriend gets pregnant, that is a contraceptive failure or an ART failure. Come on, let's be real. This is a human failure. It's not the device, by and large. So the NICHD finally decided, well, all right, we will deign to ask in contraceptive clinical trials whether they like the device or drug. That's behavioral science. Well, anyway, so that may be an anomaly in the use of review committees, but it's one I'm familiar with. So the next session, ask Paul Geist about these things. And he's going to kill me about that. But ask him, ask Willow Paquinot, who is my fellow fossil. She's also a retired NIMH person. Now, the dynamic of funding during regular funding cycles is theoretically transparent, with the advisory councils giving their recommendations to the director based on the recommendations of the peer review committees and the staff. But there's a fair amount of wiggle room, which is another place where pressure needs to be applied, steady, consistent pressure. So there's wiggle room. Now I think we will also watch, all of us will watch with bated breath as the new, revised, improved application process goes forward. But as I have said for years and years, follow the directions. Don't be innovative in your take on how to respond to an FOA. Follow the directions. So what's my advice besides follow the directions now that I'm no longer in insider. Willow has has referred to us as fossils, right? Those of us who've been working in the field since the 80s as fossils. But I'm here to tell you that fossil records can provide a lot of advice about future directions. So my advice really is, first off, and we talked about this in the mentoring day, peer review is not perfect, but over time and space, it's better than the next best thing. You know, rely on one expert in the field. I mean, that in some senses is what the many foundations think about. They've got a person who knows about it, and they can deign to award a large grant to somebody with very little other peer review. Peer review at the NIH is a long and bureaucratic process. But in effect, you know, it is the bureaucracy at NIH who is protecting us all from the behaviors of the people in that adult daycare center down at 1600 Pennsylvania Avenue. It is the bureaucratic process that protects us. So protect our bureaucrats, please. And the other issue is don't self-censor. I mean, it seems to me that you don't do that, but I know, for instance, I have heard that there is a very well-funded person in the family planning field who was at the Society for Family Planning 2 weeks ago saying the NIH is no longer funding contraceptive research. It was news to me. It was news to people in my branch. But she's a well-funded person, and she was saying that. So when you hear a rumor like that, check it out. Check it out with people who are the point people who are making decisions about funding. Because by and large, it's not true. I mean, fake news is not just something that man in the White House talks about. And also, if you believe your research is far too sensitive to be funded by the NIH, and you don't send it in, you're not going to get funded. Maybe Packard Foundation will come upon you, or Gates, or Buffett, and say, go forth and do the work. But the NIH sure as hell is not going to fund you if you don't apply, and if you don't apply in the proper formats and following the directions. So, as I say, NIH really is a biomedical organization, and we social and behavioral scientists are sort of accepted. We have to keep reminding them that John Snow did not stop cholera. He removed the handle from a pump. He didn't inject people with a vaccine. He removed the handle from a pump. That's a behavioral intervention. Behavior is critical and key. But also make sure that you check with other people about your research plan. And my other pitch on this one is that the Edmund Burke quote that we hear all the time, all that is necessary for evil to triumph is for good men to do nothing. You can bitch about men rather than good people to do nothing, but that's what Edmund Burke said. Or if you don't like that, you can also go to Pogo, and who said, we have met the enemy and he is us. And some of us in this room remember Walt Kelly and the Pogo cartoon strips. I'm going to go back and look at them again because they are relevant. They are really relevant now. So you can go on and on about purity and pragmatics, because the NIH might ask you to change some words in the title or abstract. But in my 29 years at NICHD, only one grant has been defunded after it was funded. And that was Jesse Helms' pressure about Dick Udry's adolescent sexual behavior study. He revised it, he resubmitted it, he got a perfect score. It's in its fourth round of a program project now. And you know, lo and behold, the science showed that teenagers were not screwing like bunnies, and that made the right wing happy. And so the grant has gone on. And it used to be at NICHD, and the next round is going to be given to NIA because the people who were the teenagers in the 1990s are now getting into their middle age, so it belongs to NIA. Although I like to also say, remember, NICHD is child health, which begins before birth, and human development, which ends at death. And of course, NIA says, well, human development begins at birth. So, you know, and aging begins at birth, and therefore, lots of stuff begins at. So don't ignore the other institutes as places that might be good for what you're doing. That's the self-censorship thing. Let's see, and then, I have another wonderful self-censorship. I had a small business technology transfer grant that was entitled improving the fit of HIV prevention. Michael Cecil and his crew were attempting to convince the FDA to permit a wide range of sizes of condoms to be sold in the United States. And the FDA said, no, American men can't measure their penis size, therefore we're not going to permit you to do that. They just got approval, and within the next couple of months, you are going to see 60 sizes of condoms available in the United States. Well, we all know that condoms that you buy in the drugstore could fit over that. But up here, no, sweetie, my condoms fit, they're mine. They're sized for me. So look for my own condom. It's going to come onto the market fairly soon. There was a big article in the New York Times on the 12th of October about that. You'll notice, if you read that article, no mention of NIH funding, because Michael said, we know we get grief or you might get grief, so we just kept your name out of it. So now it's going to be very interesting to see whether NIH is then pissed because they're not mentioned. But that would be very interesting. But at any rate, that's an STTR that they went ahead and did. Also, think about STTRs. If you've got a buddy who has a small for-profit business and you've got an idea, the collaboration between academics and for-profit organizations, the SBIRs and STTRs have a much better pay line. Think about them. Examine them. Well, and another issue that Judy talked about early on is the tension at NIH between funding biomedical research and funding social and behavioral science research. You know, in a sense, it's in part the tension between prevention and cure. Prevention is public health, and cure is basic science. So sometimes that's a challenge. I think that Taylor's award of the Nobel Prize for Behavioral Economics might help us in that. Use it, hammer on it, pressure again, because it might be of assistance to us as we go forward. Then Paul Gast gave me a copy of a letter by Jim Pickett, which went to Diefenbach and Fauci, about the importance of a range of prevention methodologies in HIV prevention, rather than just putting all the money into PrEP or all the money into a vaccine, that he gently suggested that there are a range of options. And I think that, again, is in the old line tradition of there are a range of family planning issues and a range of family planning responses. And as much as we give grief to the idea of abstinence, it's one of the methods, and it needs to be respected. So anyway, think about a range of responses rather than just one. Because there's no one size fits all. There's no one size to correct, to decrease impaired driving, to cut smoking rates, to decrease unwanted pregnancies. But we have to remember that even the medical answers, like the vaccine for HPV, is not used. There's still behavioral issues there to be thought about. So how then to balance the funding? Part of it really is steady, persistent pressure from you. Keep reminding the biomedical folks that behaviors are critical. I mean, go back to John Snow. Take off the handle of the pump. That means keeping up the flow of research applications. We are hearing a little bit worrying, at least I don't know about the AIDS world, but in the other parts of the social and behavioral science, the flow of applications is decreasing, which doesn't mean that, therefore, those that apply are going to get better scores, but when the flow of applications slows down, a study section may be shut down, which means that your options for real peer review sleep. So keep the applications coming. Suffering will make you beautiful. And also keep publishing, not only in the academic journals, but in the regular press. I mean, an article in the New York Times might be able to do more for you than an article in, I don't know about whether that an article in the New England Journal of Medicine or Jade's, but still, think about the popular press. Think about talking to the people from Vanity Fair, from Time Magazine, from The Economist. Make sure they know what you're doing too, because the pressure has to come from all sides. And that's really what I have to say. And it was just, for me, it was just time to go. So I miss everybody. I miss my branch, but I miss at some arcane level of bureaucracy. But I'm glad that it was time to go. And that's all I have to say. And I will be glad to answer questions, or we can move on. And it's your call, Michael.
I think we should entertain questions. Thank you very much.
All right. Thank you. Thank you for making this possible. So, questions? Or you can email me, or you can buttonhole me in the corner if you don't want to, and we can move on, whatever works. Willow, you have any comments to make? Oh, way in the back over there. Oh, Susan. You can't be a grandmother to teenagers. My grandchildren are teenagers. They don't give a fuck. So.
And they think you're incredibly unhip, right?
Oh, and embarrassing. Oh, Grandma, we don't talk about that. Yeah, anyway.
So I don't have a question. I just have a statement of gratitude. Susan, you have been there for as long as I've been in my career. And first I was doing population research as you and I spoke. Mm-hmm. And then HIV came along and I switched over. And you've always been there as a social behavioral scientist, mentor and supporter, so that when I and others didn't quite know how to handle what was going on, you were just a real voice of reason. You've always been very down to earth, which has been great. I didn't have to try to figure out, well, what did that mean? You were just forthright about what it meant. And I just appreciate the guidance that you've given me and other scientists throughout the last decades. So when you said when you came here late, I was thinking, well, it wasn't that late.
Hey, I am 78. So
okay.
Yes, it was late. I got my PhD when I was 51. So
yeah. And people, people should know that she also was very much a part of a group like this who were working in population sciences and get together still every year to talk about the social behavioral sciences and reproductive issues, family planning issues, and so forth for demography group that doesn't necessarily get our kind of research. Yeah. So you've been a real champion in both areas.
Thank you. I will make a pitch for the population meeting. It's called Psychosocial Factors in Population Control. How's that? It was started in 1972, before abortion was legal in this country, by a man named Henry David, who is now dead. But it has no PAA. It's affiliated with PAA, but Population Association of America. But PAA says psychosocial has no identifiable organizational structure. At least this R13 has an identifiable organizational structure and a funding stream. So you are much more respectable than psychosocial is. Judy.
So Susan, thank you again. I just want to add my voice to other Susans in just saying what an absolute asset you've been to all of us over the years. And I think for people who are not as familiar, what Susan has been responsible for, in my estimation, in part, one of the many things, is keeping the S in BSSR, the social sciences, the social part of social and behavioral science. Because in fact, there are very few, if any, almost no, social science program officers and staff at the institutes at NIH who are not, or behavioral social scientists, who are not psychologists. So to have someone who could always remind the rest of the more sort of psychology, behavioral science, biomedical community that there are anthropologists and sociologists and political scientists and economists and demographers, your own discipline, who have something to contribute, and to help make sure that people from those disciplines got funded is a very big deal, and something that I just really want to commend and make sure people appreciate and understand about you.
Well, thank you. I think that part of that issue is it's hard for a social scientist who's interested in, say, the structure of housing or the dynamics of kin relations in a small village to explain how that maps onto health. And the NIH, rightly, is a research organization that funds health. So making those connections is sometimes more difficult for the social scientists than it is for the behavioral scientists. But it can be done. It can be done. There was somebody else way in the back. Oh, come on, I didn't, you think I pay these people to do this?
Okay. Susan, I don't recall ever calling us fossils.
I have it in print,
And
in an
I
email.
don't think a fossil could have gotten up and given such a vibrant, dynamic talk. So I think you've demonstrated that you were not truth-telling.
Well, it's just an alternative fact. That's it. All right. All right.
So I
Thank
have
you
another
all.
question, if you don't mind. I'm wondering if you could talk about the changes that you've observed through your career in the relationship between program officers and grantees. I was first funded in '92, which I now realize is a long time ago. And I was a very junior faculty member. I was funded by NIMH, and some of you may remember Chuck Windle, who was our program officer. And he was like a senior mentor to me. He really was terrific. He took me under his wing and he guided me. And I didn't feel any kind of adversarial relationship with program at all at that point in time. And I've tried to maintain that. But I see more and more of my colleagues today that view their relationship with their program officers as adversarial. And I wonder if you could share your own view on that and talk about how that may have evolved.
Well, you know, we're human beings, and we have as many varieties of takes on things as you do. You know, that being a Fed adds another layer of bureaucracy and people looking over your shoulder sometimes. But and also, as the money gets less, and the need gets greater, the tension in program people increases, I think, because you don't want to you can't promise stuff that you can't deliver on, and people really want to hear good news, not bad news. And so I think that's the dynamic. The tension's just getting worse at the NIH and at other places too, about what you can talk about. Also, I think there's a bit more concern about they might be watching, they might be listening. I've got to be careful of what I want to say, which again, people are different, and some people worry about that, and some people don't. And I happen to be one of those that doesn't. But in a sense, I don't know why. Genetics, maybe, who knows? But at least in my branch, I don't think, that's my, my limited, I don't see that happening. Back in the office, sometimes we go, oh my God, can you believe what she said? But that's within the office. So I don't think it's changed that much. People may be a little bit more fearful to address a program officer, being seen as either being overly familiar or so the personal dynamics make a difference. And you got to cut your program officer some slack, because they are human beings and they've got other tensions that maybe they can't talk about with you. So that's it. But don't be afraid, and don't self-censor on that either. Right? And I'll be around till the end of the day if there's questions you want to ask.
Thank you very much.
My pleasure. Thank you.